Okay, with that, I'm excited to turn things over to Mindy and Brian.
Great. Thank you, everyone. It's a pleasure to be here with you this afternoon or morning, depending on where you are. My name is Mindy Smith. We are, and I'm here with Brian Peltz. We are part of the Tabula Rasa strategy team. And just a little bit about myself. I serve as the Senior Vice President of Government Professional Affairs. I've been with Tabula Rasa over 7 years, really working on how do we get information out to payers, pharmacists, and the healthcare system to really raise awareness of adverse drug events and take on opportunity on how to leverage our science. I want to also pass the baton over to Brian to give an introduction of himself as well.
Well, thank you, everybody. I know I've spoken with many of you through the years at Tabula Rasa and in presentations with Medicaid Health Plans of America, and look forward to sharing this important topic with you again today. Again, my name is Brian Peltz. I'm a pharmacist. I live outside of the Detroit, Michigan area, and I am the Vice President of Medicaid Solutions. So why don't we kick off our talk today with a polling question. Patrick, can you put the first question up?
Sure thing.
So our first question is, preventable adverse drug events are responsible for how much in healthcare expenditures? And I think you're going to be astonished with the answer.
Okay, we'll give it a few more seconds. All right, share the results.
And we have an overwhelming response of $30 to $180 billion in healthcare expenditures. Adverse drug events are, I hate to use the word pandemic, endemic, they are rampant across our healthcare system today. And they are a problem that is costing health plans, the government, our healthcare industry, as you just all answered, $30 to $180 billion in healthcare expenditures. It's important to understand that an adverse drug event is not the same thing as a medication error. An adverse drug event is an untoward event that occurs when patients take medications as prescribed at the dosages that are appropriate, but when they start to take multiple medications, those drugs interact with each other, and we have unexpected, unwanted side effects. And most plans really are unaware of the financial and clinical impacts of this on their health plan. Medication overload, also known as polypharmacy, will be responsible for at least 4.6 million hospitalizations over the next 10 years, leading to an annual cost of $62 billion. To me, astounding is that the literature shows us that for every dollar we spend on a prescription medication, we're spending more than $1 to address the problems that are caused by those medications. As our slide here indicates, if current trends continue, again, the $62 billion, and in January of this year, the Loan Institute, a nonpartisan healthcare think tank in Boston, issued a national action plan urging health policy thought leaders and healthcare stakeholders to address the issue of medication overload. Loan found that medication overload, or polypharmacy, will lead to the premature death of more than 150,000 older Americans over the next 10 years, and will contribute to over $62 billion in hospitalizations. Earlier this year, also, the Get Medications Right Institute, a nonprofit organization focused on enhancing life by ensuring appropriate and personalized use of medications and gene therapies, issued a blueprint for change. In this blueprint, the Institute recognized that optimizing medication use is the decade's most urgent and promising opportunity to save lives and save money. The reality is without proper analysis and oversight, health outcomes will be compromised and health plan expenses for already vulnerable groups of people. Over 15% of members will experience increased medication-related health risks, 10% increase in medication-related health plan expenses for this already costly population. Today's solutions aren't solving the problem. Why not? Most plans assume that their PBM is addressing medication management for their employees, but in most cases, this is not a complete solution, or they are not providing enhanced medication therapy management using MedWise. Patrick, if you can put up question number 2.
There we go.
So question number 2 is, what percentage of prescriptions are filled outside of the traditional network? Take a moment to choose an answer.
Give it a couple more seconds. Okay, last chance.
And our answers show that we have a split between 10% and 30%. %30 of prescriptions are obtained outside the traditional network. This means that existing solutions are not capturing all the drugs our employees and patients are taking. And in many cases, it's difficult to monitor effectiveness of drugs and risk if the healthcare team is unaware of all the medications being taken. 53% of adults aren't having their full medication profile reviewed before prescribing, meaning we're likely treating symptoms or conditions without understanding the risk associated with that medication in conjunction with the rest of the medications patients are taking. This can lead to reduced effectiveness and increase the risk of adverse drug events and increased total costs of care. PBMs may not have access to all this information, and that's why it's important in the process that a discussion is had with the patient to gather and collect a full medication reconciliation of everything they're taking, including over-the-counter products, nutritionals, nutraceuticals, even in today's time of multiple states allowing for the use of marijuana. We have CBD products, THC containing products that also need to be included as part of that, that medication reconciliation. We also know that patients utilize many different sources of prescriptions in that they may go to a traditional pharmacy, they may order things online, they may have some medications coming from mail order, and the ability to pull all that together into one source is difficult to do. So we're very much proponents of pharmacists being the quarterback of the medication profile for a patient, because really no one has full oversight of the medication use. And our studies have shown, published studies have shown that 33% of patients indicate that their prescriber did not even review their entire regimen prior to prescribing. What we do have available is antiquated. Pharmacy dispensing systems are using 50-year-old technology. It's one-to-one drug interactions. And if any of you have worked in the community setting, you know this can be quite frustrating in that you may get a pop-up of 15 to 20 individual drug interactions that are occurring with the patient profile. Unfortunately, these are usually scrolled through and a good analysis is not made. Using MedWise software, all of this information can be rolled into a simultaneous multi-drug analysis of all the drugs that a patient is taking. And now I'd like to turn it over to Mindy to talk about MedWise Science.
Thank you, Brian. Well, as Brian, I'll just cue in on what you just said related to the traditional one-to-one drug interactions that are highlighted on the next slide, and tell you a little bit about our MedWise science. So in thinking about the systems that we currently use today, I, as a pharmacist, I'm getting kind of an overload of information, pharmacists working on whether it's MTM or dispensing, or getting many alerts, almost alert, and have alert fatigue. It's really because these systems are only providing this snapshot, and also electronic health records have these traditional databases embedded in them as well. What we have developed, and this has been in a course of over 10 years, is our MedWise science. And so think of it as a wheel on a bicycle, where you are able to assess the combined risk of patients' medications in aggregate and really get a simultaneous multi-drug analysis. So you can look at the cumulative effects of those medications and the combined risk of what's going on. So if you add a new medication to that medication or to that patient's regimen, does it cause a cascade of other issues of the medications they're already taking and can lead to an adverse drug event? Next slide. So what we've developed is our MedWise science. And as Brian mentioned, we utilize pharmacy claims data to generate a risk score, so that we are able to really hone in and identify those very high-risk patients that are leaning towards or have high potential for a fall or a even heart arrhythmia that can come through combined risk of multi-drug combinations. So our MedWise science is a medication risk mitigation software system that provides that cumulative simultaneous multi-drug analysis to look at and provide a pharmacist the ability to see those cumulative effects all on one screen. In addition, we have our MedWise risk score that identifies patients that are a high risk from low to severe, depending on their medication combination. That risk score is assessed by looking at key risk factors. Those risk factors look at cumulative effects related to drug, so sedative burden, cognitive impairment that can occur through the combined risk or aggregate anticholinergic burden. We look at long QT syndrome that can cause heart arrhythmias and impairment. And then we also pull in the FDA adverse event risk score information. And if you think about looking at cumulative side effects that can occur, we use that reported data specifically on a patient's regimen to look at those cumulative side effects that also can lend to an adverse drug event. And lastly, one of our key differentiators is we look at competitive inhibition. So medications all go through, or 80% of medications go through our cytochrome P450 enzyme system that are located in the small intestine and liver. And medications or any chemical we put into our body, 80% goes through the CYP450 enzymes in order to be metabolized or activated into their active metabolite. So what we also do as part of MedWise is we look at and map all of the pathways the patient's medications are going through with the CYP450 liver enzyme pathways. We map those pathways so that the pharmacist can see which medications may be going through the same enzyme, but because that medication has a higher affinity to that enzyme, it may be blocking another drug from being metabolized. So then you're going to that medication is going to build up and become toxic. or it may be preventing another medication from being activated into its active metabolite, and therefore the patient's not achieving or receiving the full effect of that medication. So based on those 5 risk factors, we do a risk score to identify those patients that are at 15 or higher. 15 is intermediate level. And we really, of course, need to intervene on high and severe patients so that we can pull that risk score down and avert and mitigate potential risk for an ADE. The next slide. The other thing key point we want to highlight is that traditionally, from a medication therapy management perspective, especially, for example, in Medicare Part D eligibility requirements, we look at patients are determined eligible to receive an MTM comprehensive med review if they have so many, based on number of chronic conditions and number of medications. But we're actually missing a key cohort of patients that we are not addressing, which are patients that may not have as many chronic conditions or number of medications, but actually because of their drug combination, their medication regimen, it puts them at high risk for an adverse drug event. Their therapy is not going to be optimized, and we're missing that opportunity to intervene. So again, with our risk score, we really normalize how we're looking at who to target, not based on chronic conditions, not based on number of meds, but really looking at the combined risk of that patient's medication regimen. So one project that Tabula Rasa was a key partner in was the CMS Innovation Enhanced MTM program. So CMS Innovation set out in 2015 and announced this program where they wanted to incentivize a traditional Part D plan to actually cross the chasm from the prescription benefit to the medical benefit and achieve a 2% reduction in savings on the medical side. So as a participant, we worked with Blue Cross Blue Shield Northern Plains Alliance in their standalone PDP plan, which had over 200,000 patients. This was in Region 25, which is highlighted on the map. The 7-state region covers approximately 4.8 million Blue Cross patients. So in that specific PDP plan, what we did, instead of using the traditional eligibility criteria, as I mentioned before, with chronic disease, number of meds, cost of medication, instead we used our MedWise science and our MedWise risk score. And we took in claims data, identified those patients from the prescription claims data who was at high risk for an adverse drug event, and those are the patients we intervened on. So we used our clinical call center team to provide medication safety reviews using our MedWise science. So think of it as an enhanced comprehensive med review using our technology that leverages the insights that I provided on those key factors below or above. And also we used community pharmacy network. So we actually armed over 400 community pharmacists in the 7-state region, and we paid the pharmacists through the CMS Innovation Grant Funds, where they can earn almost $400 per patient per year intervention by providing a medication safety review. So this enhanced CMR, using MedWise science to assess the patient's risk and provide mitigation strategies to improve their outcomes. So part of that, on the next slide, the model that we used, and I kind of already said this, but I'll add one more key point, is we risk stratified, assess the medication risk scoring. Of course, medication risk scores, as Brian said, go up even more when you add all of the other medications that are not captured through claims data by interviewing that patient, conducting a medication reconciliation, and then providing those interventions. So the interventions could be deprescribing, it could be change in therapy because of competitive inhibition issues. But another key intervention that our pharmacists provide are changing medications by time of day. So in almost 50% of our interventions using MedWise science, the pharmacist will can make a recommendation in changing the time of day a patient takes their medication so that they avoid that adverse drug event because of the competitive inhibition going through of the liver enzyme interactions. And so changing time of day, if patients taking two medications that interact and they take them at the same time in the morning, by simply moving one of those medications to the afternoon or evening so that they're 2 to 4 hours separated, that actually can avoid the adverse drug event. So our science really empowers pharmacists intervention to work with the patient on making changes in therapy that are also not reliant solely on changes or the approval of the prescriber. And lastly, I'll mention too, you can add pharmacogenomics to our medication safety review. So we find in about 5% of populations that we serve, they have a drug regimen that actually qualifies and would be recommended that we add a genomics information. So that can be added into the MedWise science. And so that information for that patient's regimen is there in perpetuity going forward. So as a result of our CMS Innovation Enhanced MTM program, we published 3 articles in the American Journal of Managed Care. And I will highlight some of those articles findings, key findings. But before we do that, I think we have another poll question coming up. Patrick will display that. So our third poll question is, using MedWise science, 1 unit risk score increase results in which negative outcome? So if you have one point on that risk score goes up, does it result in a 7% increase in emergency room visits, 2% increase in annual costs, 10% increase in hospitalizations, or 25% increase in emergency department visits?
Okay, folks, give it a couple more seconds here. Okay, last chance. Okay, let's end.
All right, so we have 7% increase in emergency room visits or 2% increase in annual costs are our selections. So what we were able to find and through our, as a result of our CMS Innovation Enhanced MTM participation, in the first published article, we were able to showcase that if there's 1 point increase in that risk score, it correlates to 8.5% increase in annual costs, a 7% increase in emergency department visits, and a 3% increase in hospitalizations. So as that risk score as it goes up, so do other events and negative outcomes related to medical costs that are attributed and correlate to that risk score. In the second article that we published, we really highlight the interventions and the medication related problems that the pharmacists identified through in conducting a medication safety review using MedWise science. So in those findings, over 80% of patients, we have actionable problems that the pharmacist could actually take and do something with. Those included addressing drug interactions, drug use without indications. A lot of times we see patients taking over-the-counter medication that really cause havoc actually in their prescription medication regimen that can really cause competitive inhibition issues and lead to toxicity of their other medications, or they're preventing their prescription medications from fully being effective. So with that, we see a lot of common interventions, as I mentioned, on discontinuing, so deprescribing, changing dose, starting some other alternative therapy that goes through a different enzyme pathway, and again, highlighting changing in time of administration of medication, such as, quote unquote, simple intervention can make all the difference on how a medication regimen actually works and how we can mitigate those risks. And to highlight our third article, we were able to really quantify from our how we can impact total cost of care. And so we were able to achieve a 7.5% reduction in healthcare costs. That's attributed to a little over $950 per intervened member per year. We also, those costs were associated with a 10% reduction in hospitalizations in this population, as well as emergency room visits. And we actually had an impact in lowering the mortality rate. So if I take that $958 per intervened member per year, and I apply that to a Medicaid population where we are conservative, where approximately 11% of Medicaid plan that we took a state, we picked a state Medicaid and applied our numbers on cost savings to a Medicaid plan. This is an example where we could save over $28 million. So behind those numbers, just to show you, we're able to provide value-based contracting to provide our MedWise solutions to health plans. In taking this snapshot of the state Medicaid plan that just looking at high-risk adult population, so we don't do our program in children, just in adults, and looking at nearly 950,000 members in a plan where 11% are at high risk. So a percentage of those patients we are able to engage. We have up towards 40% engagement rate on our patients. And we apply that $958 per intervened member per year. That shows a predicted savings of $39 million. And then applying our program costs and net revenue of savings to the plan of $28 million, just in this example. So we are able to showcase an ROI of 2.5. So really robust published information that we have using our MedWise science. And we would love the opportunity to work with you on bringing this solution to your members as well. So with that, Brian, if you want to add anything, we would also take questions from the group.
Just thank you again, Mindy. The potential savings, and if we looked at all of the eligible Medicaid lives in the United States, around 80 million lives, is tremendous. And these are savings that we don't have a good handle on today, but plans are still bearing the cost of. And that's why it's so important. Yes, there is additional savings available when deprescribing occurs and the elimination of polypharmacy, but the real savings are the hospitalizations, the emergency room visits. increased lengths of stay that are due to the adverse drug events that are occurring in the population today. This is the data that we've collected in a Medicaid population is directly transferable to the Medicaid population, especially since we are looking at that subset of the population that are seniors, age blind and disabled, and adults, which we see that growing. It also fits well into the marketplace areas of plans, and in experience, most plans, when they do identify a risk stratification of patients, even in the Medicaid population, are still using that traditional Medicare, 8 drugs or more over a certain value of cost. And as we showed in the one slide, it could be a patient that's on 5 drugs and has 2 comorbid conditions, but those drugs are all interacting with each other. And again, in a senior or age blind and disabled population, that interaction, which could lead to cognitive impairment or drowsiness, resulting in a fall. We have been able to demonstrate cost savings in surgical costs, because if you don't fall down and break your hip, then you don't have to go to the OR and you don't have to go to the emergency department. So the cost savings are real. The other questions that we've had that are important to bring up is that this is just a predicted cost, and it's really not. This is a cost that was derived from millions of points of data that were collected over that 5-year time span, and that were analyzed with medical claims in that EMTM population. There was over $200 million in savings from that relatively small population. And if we look at many Medicaid plans and state fee-for-service plans, the population of a plan or a fee-for-service plan in Medicaid is much greater and closer to the entire population that we saw in that EMTM project. So we are excited to continue the conversation with you about this. My contact information is on the last slide here. I know Patrick can also connect you with us, but we would look forward to your questions at this point in time.
Okay, wonderful. We have 2 questions so far, folks. You can still ask more using the Q&A button. We encourage your participation, but let's get started. I think this question you may have discussed a bit, and especially with your last slide on the seniors ROI. But the question is, how does MedWise work in the dual population? Which I assume with regards to ROI.
The dual population is more difficult because their pharmacy benefit is going to be paid for under the Part D benefit.
Right.
So there's still value in performing a medication safety review in that population, although the plan would still be required to do a traditional MTM on that patient. What we do see even is, to use California as an example, states that have carved out their pharmacy benefit, the plans in the state are still very interested in conducting medication safety reviews. One, because they're still responsible for the overall outcomes and safety for their patients, but also that the savings are on the medical side, which are not carved out. So if we can work with patients to improve their medication risk profile, that will reduce overall cost of care, which is still important to plans that are not responsible for just the pharmacy benefit.
Absolutely. Very helpful. Thank you. Okay, our last one. Do you have any data on how MedWise affects emergency department visits?
Yes, the data that we presented showing a reduction in percentage, a 7% reduction in emergency room visits. We do have extensive data that's published on that. And if you request the slideshow, those 3 articles will have that data within them. Or if you want to send me an email, we'd be glad to provide that to you.
Okay.
That population that received a medication safety review did have a real decrease in emergency room visits overall for the population.
Okay, fantastic. Well, those are our questions. I want to thank Mindy and Brian and Tabula Rasa for all your support. This was a great presentation. I learned a lot. It is amazing how much of an effect, obviously, medications have on a patient's in addition to so many other facets. So this is a great tool. So thank you again, Mindy and Brian, for your presentation. Everyone else, please keep in mind, this recording will be on our YouTube page. And then again, lastly, if you'd like the slides, you have Brian's info there, or feel free to contact MHPA. So I want to thank you guys one more time and our attendees for coming out this afternoon. I hope everyone has a great afternoon.
Thank you.
Thank you.
Bye-bye.